mindful and switching into that in terms of changing behaviors and health outcomes. And again, that's just going back to them. I told them they should know. Be very aware of falling into that trap. Just because you give people information, just because you give them brochures, doesn't mean they actually engage. It's critical that you learn that and that you keep that at the top of your mind. Non-judgmental. I find no matter what I'm doing, the minute I start beating myself up, I'm almost guaranteeing I will do it again. The most effective strategy, if I have not gone and studied that day, if I have not gone and hit my goal that day, I will resist the temptation of kicking the crap out of myself. And I have found that it's always far more powerful. I say, okay, it's fine. This is what happened. Calm down. Calm down. Go back. Go back through it. It's okay. It's fine. And I have to just, and once I get the attack dogs off my back, now I'm in the position of giving myself the freedom or the choice or the space to actually go and do it. Again, it's a type of form of mindfulness. So if patients are coming in and they're sort of saying, oh, well, I meant to do this or I meant to do that, you know that they're attacking themselves and then they're also apologizing to you, you may be sure they're not going to be changing their behavior anytime soon once they're in that mode. So it's trying to sort of like get people to be frank with you, to be honest, to relax. You had a cigarette? Don't worry about it. Doesn't mean that you are back smoking again. Just smoke less or just give yourself a break. It's okay. The smoking is not healthy, but it's okay. Just relax with it. And then I think it gives people a lot better chance to give up or change behavior, whatever it might be. Or you didn't floss, it's fine. Just go back and figure out what's going to make you do it the next time. Is there any way that you can motivate yourself to actually find flossing fun? The alliteration's fantastic, isn't it? And I think it's also about generally, whatever way you do it, to communicate that message. We're on your side. We want you to thrive. We want you to do well. We're not here to judge you. We want you to do well. We want you to be honest with us. We want you to be frank with us. We want you to be open. We want you to realize, look, that's not going to get you there. I don't need you. This is not a confession box. This is a dental chair. It's not shame and guilt is not going to get people to change their behavior in things like that. Written commitments, as I've said already, are useful. Telling people that you can succeed, but also saying it will be difficult. If people go into diets or people go into try and do smoking cessation or whatever it might do, and they underestimate the task, they think, oh, I'll go out there and I'll do it. They have good research from Carol Dweck, and Heidi Grant Halverson also will report that in Succeed, about the success comes from people who understand the challenge that they're taking on and how difficult it's going to be. And then there's just a simple, just to go back to that, a simple kind of, this is my programming background, is excited by this kind of stuff. When it is X time, I will do Y good, whatever it might be. So it's a simple, placeholder kind of idea that when I do this, well, then I will do that. It's like how to just lock into, the pattern-forming behavior that will do things like when I go to bed at night and I look in the mirror, then I will pick up the floss, or I will leave the floss out there, or I will leave the TP brush, or whatever it might be. Again, health literacy, I'm going to come back on that subject again. We see that orange juice, is an orange juice great? I go to Spain, I spent some time there, and I saw an afternoon show there once, and they're going, mira, ¿cómo está? Muy bien, una desayuna muy bien para los niños, es este. And it's all they're going on about how wonderful it is. They can have their cereales, which are full of sugar, and then they have their orange juice, which is going to rip their teeth apart, spike their sugar level up for the day. There's no banking down of the fire. It's just like pure petrol into the stove kind of breakfast. But this is being promoted to parents who are watching, that this is a healthy breakfast. And I'm saying, no, this is not a healthy breakfast. Wine, of course, we're told. What's the great benefit of wine? Has anybody heard about the heart benefits of wine? Hands up. Do you believe it? Hands up, who believes it? No! I believed it for a long time as well, but I had skin in the game. I liked wine. But it's just a sugary drink. It's grape juice with alcohol. I have no problem with alcohol. I'm Irish. I mean, like, it's part of my culture. It's part of my DNA. But it's not healthy. It's just one of those things. We've got a sort of like a wine industry and we've got a beer industry, and they're convincing people this stuff is good for you. It ain't. Resveratrol, by the way, how much resveratrol would you have to drink? How much wine would you have to drink?
2 cases.
Go again.
2 cases.
How often?
Probably daily.
3 cases a day. So if anybody wants to get those resveratrol benefits from wine, get yourself a very large bank account and 3 cases of wine a day. Your heart will be in fantastic order and your liver will be kaput after a week. So there you go. There's your daily supply of wine to get your resveratrol. Okay? There's your French paradox. And yet these are so common. These, you know, you ask most people and they will say, oh yeah, wine, it's good for you. Yeah, it's garbage. It's nice though. Teething pain. I had a chat with Ollie on the way across here this morning. Teething pain. Do babies have teething pain? No. Their immune system is adapting at that stage. It happens to be happening at the same time. But most people will tell you, teething pain. And they will give you this Blowingella, and they'll give you this thing for biting on and everything like that. I have 2 kids. I was convinced they had teething pain. I was convinced their diarrhea was because of the teething. They're teething. That's what the diarrhea is. No, it's their immune system is forming. But again, this is just giving you points as regards how much health literacy in the public is quite poor. And you are, you know, part of the community that will really have to just get these messages out there. Toothpaste overnight I've already covered. And there is just what I would call in mental and moral science, we call it benign paternalism. This idea of freedom of choice. I heard oncologist John Crown, he's a senator in Ireland now, and he was on radio recently and they were talking about tobacco. And the presenter on the radio was saying, but if you raise the price of tobacco, it's the lower socioeconomic group is going to end up paying more for it. Is that not unfair to them? And he answered, he says, no, what is unfair to them is having their legs amputated, having their lives cut short early. So I do believe that take permission to go for benign paternalism. We are bombarded with information from people who are selling all the time. And the only real chance we have are people from public science, public medicine, making the argument against and getting the information out there. Myth busting, public discourse, health literacy, all of those things. And one of the paradoxes of good healthcare and good medicine is if you do your job right, you'll be out of a job soon. Okay? And there we go, that's the end. So we'll go to the Q&A. Thank you very much. Thank you.
Thank you, ADEE. And I think that most of us have seen that we have the Padlet opportunity, but we go traditional with microphone in order to elicit some questions. Please, I see already, Rebecca, please, on that slide.
Okay. Oh, okay. Oh, sorry. Okay. Thank you. Thank you very much. Thank you.
And ADEE, sorry,
there's no sugar
just
in
one
this,
question.
is there?
So sugar,
Oh,
yes.
it is. It's sugar. I'm being given sugar at a dental conference.
So,
thank you.
let's go to the questions because we are in a hurry.
No problem. There's also a voucher for dental care.
You have to go back to work.
Excellent.
Now
Yeah.
you are an
I'm going
actor
back. I'm going back on a flight today.
Okay, no, please, the first question, down
Okay.
there. American.
My own, yes. First of all, I wanted to congratulate you for forgiving the profession for misdiagnosing you.
Okay.
Second, Could you list the interprofessional team?
Could you speak?
Could you list the members of the interprofessional team that treated you over the last 20-some years?
The different professionals?
That's correct.
I was with radiotherapists, I was with psycho-oncologists, which is very, very important. I was with surgeons, ENT surgeons, general surgeons, dental professionals, dental hygienists. There may be others in there, but I mean, like, we're talking about 1993 to we're talking about 22 years now at this stage.
If you could go back to 1992,
yeah.
What would be, and knowing what you know today,
yeah.
What would be your ideal arrangement to reach this interprofessional team?
The ideal arrangement would be you go to your GP, okay, and your GP says, I'm not sure what's going on there, it's in that area. If they send you to the hospital and you go to a general surgeon, they should be able to hold their hands up and say, this is beyond my competence. I'm referring him to a multidisciplinary team that they can make an assessment. Don't touch the person until you've got an assessment as regards what's the most effective modality of treatment at that stage.
Okay. Thank you.
Right. Thank you. Any other questions? Yes, please. But I repeat, please remember that with Wi-Fi access, you can have Padlet on. Please.
Thank you very much for a very stimulating discussion. I have to confess that I have some resonance with you because I too had a head and neck cancer at one point, and some of you may know this. One of my questions is that when I trained as a dental student, head and neck cancer patients, most of them didn't survive. Now a large number do, and you are testament to the fact that many years later, there are a group of patients around who have had this experience. I wonder whether your very presence here is illustrating to the fact that to many of us, the fact that there are so many people walking around now successfully having received cancer treatment is something that we are not aware of. And we as a profession need to be made aware that times have changed. A lot of people have had successful cancer treatment, and we are not yet sort of psychologically in tune with dealing with the morbidity of the treatments, the dry mouth and so forth. And perhaps I wonder if you think we have to adjust our own attitudes to saying, well, you guys are really going to come into our surgeries and we are going to have to treat you, and therefore we need to be made more aware of the sort of experiences that you are.
Absolutely.
Yeah.
Absolutely. I think there's a couple of things that I would take away there. Number one, I think it's important, and it's not hokey, to let you know, and especially let people know that this is the result. The treatment I got initially was all over the shop. Okay? And then I was pulled out of the fire in 2002 by an excellent team. But I had to go to Sloan Kettering in New York for second opinion. I had to go to Royal Marsden in London, and I had to go and make contact with several other cancer centres around the world because we're dealing with a rare, unusual case. I just don't want to see people with rare, unusual cancers going through the same unnecessary trauma that I went through and the risk that I went through. I'm very lucky to be here today, but it's the type of luck that's just unacceptable luck. It was flip of a coin luck that should not have come into play. There's types of luck that happen when you get the best treatment. You still need a certain level of luck. But I'm talking about the difficulty of even getting to good treatment was there, and that shouldn't be there. So that's another point. You are going to see more patients surviving, and that's a thing that you should be proud of, that we are getting results. But at the same time, there's also so much where people are not being channeled into the right treatment correctly and quickly.
Hello, Alison Dougal from Dublin. As a patient, now there is a growing cohort of people who are surviving mouth cancer. And so we would advocate, or certainly it seems suitable for lots of patients to be seen in general dental care. As a patient, what would you expect of your general dentist? And what would you expect as a professional trying to encourage patients like yourself to go and see general dental teams? What would encourage you to actually come away from that team who perhaps have seen you through the acute phase or the post phase? Because that's a challenge for us as professionals to liaise with patients. Yeah.
Oh, there's a question here.
This question is mixed with another one.
Oh, is it? Okay.
Yes. So how do you overcome long-standing social expectations and paradigms? I think it's connected
It's a very similar question.
Okay. So.
Well, okay. Personally speaking, I recently spoke to my oncologist. My GP had mentioned to me he may be retiring soon. I don't want to see anybody but him if I had a choice. He won't be retiring, he told me, but I want to see him. And I go into the dental hospital, I know the people I want to see. And you can have a chat with me after this, and I'll tell you why. I just don't trust people who have lesser competence than the people I'm seeing. I don't want to be there as a test dummy. I'm not prepared to play the roulette anymore for the healthcare system. I've been through so much stuff where stuff had been missed, wrong treatment had been given, information was wrong, being sent in the wrong direction, and ultimately, if I didn't have the type of neck, pardon the pun, that I do, and the kind of bullheadedness that I had, I wouldn't be here today. So, as regards going out into general, I don't want to see a general practitioner. I want to see a specialist who knows exactly the kind of treatment I need. That's what I want. Now, I can understand there's a resource issue, but the resource issue should be, there should be triage that effectively says, this is beyond my competence, you're going there. I had the opposite. I had people operating on me that shouldn't have been going near me. They should have been passing me along. So that is one of the things to keep in mind. Head and neck cancer is for head and neck specialists. It's not for general care. And when it comes to the dental management of it, I want to know that I'm dealing with not a generalist, but a person who has competence, who understands radiation effect, late radiation effect, demineralization of bone, all of these things. I don't need to be taking any more risks where somebody goes, oops, I didn't realize that. Well, sorry. I'm the one who's going to have to live with the consequences, and they're pretty serious.
So that's interesting, because you've given the list of what you would expect from your from your dentist.
That's where
so those would be the key things you would ask for.
I only want to see somebody who really is damn competent in what they do. It doesn't mean something can't go wrong, but at least it's narrowed down to things that are down to, well, couldn't really be avoided. I don't want to have avoidable mistakes anymore. So that's the reason why I would be reluctant as regards going beyond that.
I have to catch the time, so please, do you mind to pass down to Christoph, just behind you? Just behind you? Lovely, because I trust Chris to be very, very short.
Yes, I will be very short. Thank you very much for your kind lecture, and I really appreciate your point of view as a patient. However, you delivered a very strong message when you actually listed a few books, and one of them was the Alan Carr book, How to Help Patients Quit Smoking.
Yes.
And you had really referenced this book well, because the way Alan Carr is presenting the issue is that he kind of downplays the nicotine role in the addictive process. And as the oral health professional point of view, and in terms of helping patients to quit smoking, I would really rather give the nicotine still the role as the addictive molecule in this entire process. So I couldn't have your point of view just stand in the room as itself, but nicotine is the issue of tobacco dependence.
So you're making the argument for the nicotine addiction. Okay, I'm not making the either-or position.
Right.
And I can understand how you could argue that, but I can tell you that it's not just nicotine. And if you take a look,
that's right.
Yeah,
that's right.
If you take a look at if it was a case of just nicotine, you just give somebody a patch and then tra-la-la,
right. No,
they
it's
all
two.
give up.
The tobacco dependence is a twofold disease. It's physiological and psychological.
Absolutely.
Absolutely. And I just couldn't have the nicotine downplayed that way.
Oh, yeah.
the
No,
Alan
no, I
Carr
hope,
books.
yeah.
But I
yeah.
really want to point out that that's often the patient point of view, and that's really what I appreciate from your lecture.
Yeah.
But we could not have this just be the only point of view.
Yeah, no,
and I
no,
would like to
accept-
balance that out.
yeah.
That's why I took the microphone.
Yeah, yeah.
Thank
no,
you.
I think it's
Thank you very much.
I would think from my experience of giving up smoking, that was the book, because it got away from this whole idea that it's about nicotine. It's not. If you sort of like just say it's when you're out in social interactions, you feel a little bit awkward. What do you do with your hands? All this kind of stuff. Or you know, and when you become mindful of that, it's not about nicotine. I don't go around saying, oh my God, I want to get nicotine. Even though there is an addictive component, and I'm not denying that. He probably goes over the top on it, and he sort of like doesn't recommend Nicorette or any of these kind of patch things. And you know, he makes this, I think he goes too far on that argument. But what I'm saying is, most of cigarette smoking is about habits that are formed around the ritual of having the cigarette.
Thank you very much. This is just meaning the round of applause for ADEE, because
Thanks very much. Thank you.
thank you very much.
Thank you. Okay. We'll see you.
It was exactly the type of communication we wanted to have from internal.
Okay.
And of course, Chris is the person that is going to have a lot of space in ADEE for the future about this type of communication from a professional perspective, but we wanted really your message coming from the heart.
Okay. Thank you very much for being here this morning.
Thank you.
Okay, thank you.
Thank you very much.
Okay, thank you. Yeah.
So it's my turn now to act as a real presenter. So it's my pleasure to ask Tricia O'Hare to come, and I would like to introduce her and ask, please, as you see, to consider that the system is on board because we are streamed all over the world. So please consider that I have to take into account also the questions that are coming from abroad. And you will see them here if it is needed. Tricia, she's pioneered the position of periodontal therapist in Arizona and worked for several years teaching local anesthesia and providing local anesthesia in an oral surgery practice. She has completed training in both oral myofunctional therapy and buteyko breathing. In addition to extensive clinical practice experience, she is an international lecturer, educator, administrator, writer, and consumer advocate. The focus of this education is inquiry, reflection, and achieving behavior changes in the dental practice. She's authored 26 years of Perry Reports research summaries, the textbook compendium of current research, contributed to the text Comprehensive Dental Hygiene Care by Irene Waldwell, and Comprehensive Periodontics for the Dental Hygienist by Mia Weinberg. 3 articles have appeared in Hygiene Town, Dental Economics, GDR, and so on. But what is more important is that she's here to give the heart again of the communication in this type of aspect. Thank you very much for your lecture.
Thank you very much for that lovely introduction and for inviting me to be here as part of this conference. We're going to focus today on a little bit of what Edward has been talking about, but just more about how we can help students as well as patients achieve their behavior change. We're going to look today at dental education and how it focuses so much on competencies, not as much on outcomes. The need for behavior change. Do we even need people to change behavior? Thank you. And we'll look at a technique for asking questions and just beginning the steps into behavior change, because as I learned from the workshop yesterday about behavior change, the research is showing that 9 to 16 hours of training are needed to learn behavior change. So in our 30 minutes today, we won't be experts, but we'll certainly have a little peek at what could be done and an opening step. This is the textbook that we use with our dental hygiene students. I teach dental hygiene students who are licensed and registered already, but who are working to complete a bachelor's degree. And luckily, we have Christoph Ramsayer in the audience, and I brought my book, and I will have you autograph it later. Thank you. But definitely a great book, and our students think that this should be in every curriculum, and they wonder why they weren't taught this when they were in school. Why were they taught to give a lecture to patients? So this is the one we use. So can I just ask a quick question? How many of you are educators? Very good. And how many are students? Great, great to have the students. When we talk about motivational interviewing and behavior change, it's not usually done with a lecture. That's not how you effectively change behavior of a patient, is to lecture them. It doesn't always work with dental students either. It should be more interactive. So I will try to get a bit of interaction today, and I'll ask you first to just answer 2 questions to yourself and just jot down or remember what your answers are. First of all, on a scale of 1 to 10, how important do you think it is to focus on behavior change in dental school and clinical practice? So 1 to 10, okay. And on the second question, 1 to 10, how open are you to changing your approach? Not everybody's open to change. Ask any married couple. They're always open for the other person to change, but not necessarily themselves. So in looking at the first objective, looking at competencies, what we see in dental education, dental hygiene education today, a big focus on learning all of the steps, all of the intricate parts in order to achieve the goal of the restorative procedure, the surgical procedure, the dental hygiene prophylaxis. So we see lots of different areas. There's just a few listed here. And if we look just at examination and diagnosis, you have so many parts, many more than this. But each of these parts has so many competencies within. And when you look in the US at the accreditation standards for dental and dental hygiene programs, it's an enormous book filled with all of the list of the competencies, all the steps that are needed. But unfortunately, what we aren't being asked to do is look at how healthy are the patients in the end. Did the patients achieve better oral health?